So this last part is a talk about changing slightly the paradigm, at least now that we have in our hands beautiful equipment that can make life easier for us when we treat keratoconus. We used to remove epithelium, and when you remove epithelium, some things are not in your favor, like you delay the healing when you do cross-linking as well. You may have sterile infiltrates, and you may have infectious keratitis, and you certainly have a little bit or even more significant scarring or corneal haze. But when you take the epithelium off, certainly you have a more efficacious way to treat the cross-linking. All the randomized control trials have shown that standard cross-linking is much better and more effective than the transepithelial one in all the aspects. But we were missing something there. And what we were missing, another element that we were missing when we were treating cross-linking was oxygen. We have UV, we had a photosensitizer, but we didn't consider oxygen in the beginning as a major player when we treat patients, especially when we decide to treat transepithelial cases. And also, we didn't know about that much about oxygen-mediated and non-oxygen-mediated pathways. And the oxygen-mediated pathway, the type 2, was the most important in an effective aspect in the change of collagen in the cross-linking. But unfortunately, when we do cross-linking, oxygen consumption is rapid within the first seconds, within less than a minute. And then you have type 1, the non-oxygen mediated type of cross-linking for more or less 10 minutes. So we had somehow to change this and to have more hyperoxic environment when we do cross-linking. And that can be done when we have an environment with 90 or even 95% oxygen around the eye when we do the cross-linking. And we do that by using this device, which is a device linked with, connected with oxygen. These goggles can improve dramatically, as you can see, the way we do cross-linking. Adding on that, the customized cross-linking that we're using, and Dimitri had described before, the way you do customization in any form or any shape you would like. This is the first protocol that we use with the 3 circles. So we put all that, riboflavin, special riboflavin, oxygen goggles, and pulse-targeted UVA. You can have this new treatment, this new thing that we are adding now into our way that we treat cross-linking. And the results of the first study showed a very impressive improvement on the best corrected visual acuity, as you can see on the right. Kmax reduction similar to the standard FEBOphth procedures, and demarcation line as deep as the standard FEBOphth procedures. Here in the demarcation line, you can see that this is the first circle where we use the most energy, and the demarcation line goes as much as 3/4 or 350 microns deep. And you have the second level of energy and the outer circle in the periphery. The demarcation lines of our patients, as you can see, there were 24 eyes, and all the eyes were above 220. And the mean demarcation line depth was 352, exactly the same as the standard cross-linking mean demarcation line that we have in our original Dresden protocol. So we do that in cases. Here's one case, a 19-year-old student with keratoconus. We did an epion curve on the wear side. You can see on the difference, marked flattening here, 6 months after the case. And this is a comparison between 3 to 6 months, and you can see that this the developing, the change of the collagen, which happens even 1 year. Unfortunately, the eye that we didn't treat at that time, the untreated eye, developed thinning. And this remarkable thinning, of course, leads us to do cross-linking on the other eye as fast as we can. And these are the appearances of the eyes after cross-linking. You can see the central area, the more peripheral ones that we do cross-linking. This is another interesting case, a 12-year-old boy. You can see the marked flattening. So we can do safely epi-on our little fellows with keratoconus and stop the disease. This is a marked flattening. So customization plays an important role. We can still looking for better strategies with different plans, different energies, and hope by changing that we can have even a stronger cross-linking effect. And this happens because we have the ability now with this new equipment by Avidro. But okay, let's try to think how we are going to take all these advantages of the new technologies that we have, like cross-linking, the intracorneal rings and all that, and adapt them in the cases that we have in front of us in all these keratoconic patients. I think there are 4 aspects which play an important role on this. This is the corrected visual acuity, the thickness of the cornea, the amount of coma or the RMS, and the progression, which in that case is basically the age of the patient. So when we have thick corneas with good visual acuity, I think the just epi-on curve will be good enough when you have low RMS, or if you have high RMS, high coma, and the visual acuity, the corrected visual acuity is not as good as in the other cases, you can improve the shape of the cornea, the anterior surface of the cornea with topo PRK or with intracorneal rings, and add, of course, cross-linking. In cases of thin corneas, but in thick corneas, but even poorer visual acuity into the level of 410 or 210, then, of course, we have to consider dark. You may again try to do topo PRK or even combine it with customized cross-linking to have more of the effect on changing the shape of the cornea. And of course, as we said with the previous one, you can try intracorneal rings, but topographic PRK and intracorneal rings in these cases, usually they're a little bit of more unpredictable as in other cases. And I think the lower the visual acuity, the best the candidate for deep anterior lamellar keratoplasty. In thin corneas, I think epi-on in these cases with the low RMS is a very good case because you can still use the cornea that you have and the epithelium as a safety margin for doing cross-linking in cases that you otherwise couldn't do because the stroma was too thin. But when you are having very low visual acuity, epi-on curve is not going to help you. I think these are, again, cases of deep anterior lamellar keratoplasty. And I would like to thank you with that. And this was my presentation. And of course, I'm sure that this presentation will create a lot of discussion with our friends. Damien and Renato, you're still here. Good. We still have a few minutes. I know that this presentation, the last presentation, created a little bit of discussion. So I'm happy to have you and discuss all these changes that we have now into our armamentarium. Renato, what do you think?
Congratulations for your talk. I am learning a lot about the new KXL2. I don't have I do use the KXL1, and other cross-linking machines that are available here in Brazil. I am very much positive that the epi-on cross-linking is the way to go, because when we started talking about cross-linking, people would say that cross-link is like a vaccine to treat the patient before the disease comes. And in terms of the concept of the vaccine, the treatment cannot be worse than the disease. So if you do cross-linking in a patient with the FEBOphth Dresden protocol in a patient that does not need the cross-linking procedure, you may cause more harm than benefit. Epi-on is different. And I do believe that Epi-on has the great clue for the surgeon, which is the epithelium. So the epithelium is going to mask the UV and blocking in the area that is thicker. In the thinner epithelium, which is likely the places that you need to have more cross-linking because of the epithelial mapping, as we see with the OCT technologies, we believe that the epithelium is going to be the best customization protocol, as we do for the transepithelial PTK for therapeutic cases, and use in which you later use some masking agent like the Paulo Vinciguerra technique. So I think the Epi-on is the way to go, and I'm very happy to see your experience, Kamasota experience as well, and all the movement towards the Epi-on, because we'll be able to expand the opportunity to treat the patients in an early fashion in a more safer way. And it doesn't give you less the importance of the eye rubbing, of course, but cross-linking Epi-on is definitely the way to go. And I'm very happy to see the nice results that you shared, which is pretty much in agreement with the ways I do Epi-on as well. But it's still a little bit of more art than a true standardized scientific proven procedure.
So
Yes, yes, you want to add something, Demian?
What is your share between FEBOphth and Epi-on today? What is your approach?
I have to tell you that we have this 2-year follow-up of most of these patients, and these are the results that we have, the paper that we have sent to Journal of Cataract and Refractive. At the moment, I can tell you that it's about 50 to 60% of the cases that I do are Epi-on cases.
Mm-hmm.
And I leave FEBOphth only in the cases that I have severe RMS change, severe coma, and severe low visual acuity, and I want to change slightly the coma. So by using the squint, I'm trying to relocate as much ablation at the coma, at the cone, but not too much. And in cases that I have a good visual acuity, the level of 7 out of 10 or 6 out of 10, I just do curve and Epi-on. And it does change a lot and does improve the visual acuity. And it was a surprise for me. It was a surprise. And the other important thing that we have in the paper, I didn't want to spend too much time on this on the talk, is that we have a correlation between demarcation line percentage on the cornea and improvement of visual acuity. So this is something that tells you that, yes, we may be able to have a deeper penetration, but a more effective penetration, which does improve the visual acuity. I don't know. It is not preliminary data. These are cases that we have. Most of them we have also about 2 years follow-up, and it's and they're about 25 eyes. Now I have done more than 50 cases on that. So I do use it a lot. I do use it a lot, and it's also fantastic for the children. You know, when you have children, it was always a bit of a puzzle whether you want to use FEBOphth procedures. It was a bit difficult to have the contact lens. Now with this Epi-on, I think you will have the effect of the standard protocol without removing the epithelium, and this for me is fantastic. And we do have a lot of pediatric cases.
Interesting.
This is interesting because I do follow the Greek from John Kanellopoulos and Giorgio Chimionis on the Athens and the Cretan protocols. The difference is if you do PTK only or if you do some form of topo-guided or tomo-guided ablation. I think the topo-guided ablation is a great tool, but eventually with just the PTK, as you just described, just do the PTK removal is the best way to remove the epithelium. So, but if you don't need to remove the epithelium will be even better. So the Epi-on is definitely the way to go, and we are all moving towards this as an efficient cross-linking with the Epi-on protocol. Very, very nice.
We were doing the John Kanellopoulos procedure. John is a very good friend of mine for many years. But we all had patients that trouble us. We didn't understand why they didn't go as expected. And I mean, I do understand, because cross-linking can be sometimes unpredictable, even if you do it in the same time with PRK, or let's say because you're doing it in the same time with PRK. And also
I have a question, actually a comment from a friend that just sent me on the WhatsApp about the combination of PRK and cross-linking as a prophylactic procedure. I would say that's probably one of the most important misunderstandings of people, because cross-linking is not like a prophylactic antibiotic for preventing infection that you don't want. So just doing everybody and then you prevent ectasia, which is a very bad complication. If you do cross-linking along with surface ablation as a refractive procedure, I think then you have exactly what you just described, very unpredictable results with severe flattening over time, irregularity, and those patients, they do very bad. So I think cross-linking is something that is needed when you have a therapeutic procedure for ectatic corneas. And if you have a borderline cornea, you may even consider not doing a cornea refractive surgery, but a phakic IOL, which is going to be safer in terms of an elective procedure. So that's why I do compare the lion and the cat. They have a lot of similarities. Surface ablation is surface ablation, but surface ablation, a patient that wants to get rid of myopia glasses, is different than patients that don't see well with glasses and need some transplant eventually. So those are different situations, and we have to acknowledge that.
You know, Renato, once you have a case of cross-linking that you did PRK cross-linking and they end up with +5 of hyperopia, then you start regretting of doing the combination. Yes. And we all have these kind of cases that end up with a hyperopic result throughout the years. Dimitri, we have Vasilis Liarakos with us.
Yes.
We all know
I just want to comment on what we said about the combined. It's a very selective. It's not for everybody. A patient with keratoconus has to understand what the problem is. It's not the refraction, it's the instability of the cornea. And our concern is to do something to stop this progression, not to give per se a better quality of vision. This will follow. And if there are good circumstances to follow, then we may proceed further on to do something additive, in addition, a PRK ablation, excimer ablation, or to put some intracorneal rings. But the main concern is to understand what the problem is, to stop the progression, to have a better cornea, and if we have the ability to offer a better quality of vision, no matter how and no matter what, we will do it.
True. This, of course, Dimitri, this all is in the ideal world. Sometimes our patients are impatient and they want everything to be fitted in one operation. We have to guide them in a certain way. So we have an interesting case. I would like to say hello to Vasily. Unfortunately, we cannot see him, but he sent his congratulations, and he has an interesting question. How would you approach progressive corneal thinning of the host keratoconic cornea after an old penetrating keratoplasty for keratoconus, especially when it affects the graft-host junction area and the thinning is below 300 microns? This, a bad case. So pick up your brains, whoever wants to start answering this question.
Well, I will answer this question, and then I unfortunately have to leave because I need to get my kids at school. This is my day of getting my kids at school. So
we are very lucky to go to school.
Do they go to school?
We have them at home. We have them at home, quarantined.
It's been a month ago, then they started coming back, and they don't know until when it's going to last. But it's a crazy world now. But going back to the case, if you have a peripheral thinning, that's what I say is a recurrent keratoconus or a recurrent ectasia after penetrating keratoplasty. It typically occurs in patients with advanced keratoconus that rub the eye a lot, and I think it's a recurrent of ectasia because you see the thinning in the patient's cornea, and the transplant is very thick. So what I typically do in those cases, I use now the femtosecond laser to refine the cornea and have a little in towards the patient's cornea, towards the limbus, and then I suture with a topoplasty that I learned from my professor, Dr. Civintal. And this is published in the Brazilian Journal of Ophthalmology, and it's very easy. If you do topoplasty and put my name, T-O-P-O-plasty, topoplasty, you just retrefine and do suture. I have a friend that does retrefine with a blade, go inside the eye, and then he rotates 45 to 90 degrees and saves the cornea. And the possibility of having this as a best procedure is because most of these cases, the endothelium is very nicely in an immune tolerance with the host. So it's a very nice idea to keep that cornea if the cornea is transparent. A corneal ring is also possible, but you need to see the thickness in the periphery so that you are sure if it's possible or not. So this is a very interesting situation. I have seen Seiler showing the peripheral cross-linking in an annular fashion for cases like this one, but some of these cases are very thin. They are like 345, less than 400 in the periphery. So I think the suture is probably one of the best ways, and eventually having a little bit of tissue out along with this dissection may be a good idea as well.
I agree with what Renato said. You can also try tectonic graft in addition to the previous graft. I've seen cases like that, but there are risks of rejection and inflammation. But in some cases, when the thinning comes to be very, very thin, that's all you have to do is like a patch of a stromal cornea that you can find on a bad donor, for example, or something like that, and then you can tailor it to the shape you want and put it like a little inferior bandage at the junction, and that may
a little banana. Let's do a little of a banana-shaped kind of cornea. Yeah, that is a big. I mean, I had a similar case where there was not a keratoconus,
pellucid. You had with a pellucid when we put a banana-shaped intrastromally piece of cornea in order to strengthen the periphery of the thinning of the peripheral thinning.
Instead of cutting the whole thing, I just make a pocket, put a little bit like 200 microns or 150 microns of stroma in the thinnest area, then put a suture at the paracentesis, and that's all, and makes this little area a little bit stronger. But I don't know whether this will hold the whole situation, but in some cases may work. I have Googled your topoplasty, and I will have a look.
Me too. I've done it here. It's very
okay, guys. I'm sorry, I will have to go.
Yes, everybody has to go. I think.
Thank you very much. I think we certainly enjoyed that, and the audience enjoyed that. Hopefully, in a years to come, we'll see we join ourselves strong and in a personal manner. Thank you very much, Paris. Thank you very much, Brazil, and thank you, Siena. Bye bye.
Thank you again.
Bye bye.
Bye bye.